And on behalf of everyone at Research with a Heart, I'm so excited to welcome you to tonight's event. We have a really exciting program in store for you, but before we get started, for those of you who may not know about us, I just want to give you a brief intro into who we are. So at Research with a Heart, our vision is to elevate everyone and to rehumanize research. And how we do that, our mission is to provide access to equitable and inclusive research opportunities through community collaboration and engagement. And our values that we carry with us as we conduct our research are community, integrity, compassion, innovation, transparency, and connection. And so as a background of what we do, so our clinical research center is located within the infectious disease practice in Newark, New Jersey. And we're actually one of only 2 sites funded by the Division of AIDS, also known as DAIDS, which is part of the National Institutes of Health in the entire state of New Jersey. And we've been in operation since 2005, so almost 20 years, give or take. And to date, we've actually successfully enrolled over 1,000 participants for research studies with HIV, COVID-19, addiction and treatment, and much more. And so where we're located, our practice is really based in Newark, New Jersey. Our primary center is the Ambulatory Care Center in University Hospital, but we also have a site at the International Center for Public Health on Warren Street. And we also conduct some of our studies out of the Behavioral Health Sciences building, which is also in Newark. And as an idea of what we've done in the past, some of our most notable studies were our COMPASS study, which during the peak of COVID, we went out to determine the prevalence of COVID-19 in the community. We were also part of Mosaico, which was a study about an HIV vaccine, HPTN 083, which that data actually we're really proud of, resulted in long-acting injectable cabotegravir being approved as a form of PrEP. And we were part of the Moderna trial as well. So we've been part of some really exciting studies. And then kind of looking forward into the future, some of what we're currently doing includes our A5391 study, which is a study to determine if persons living with HIV who might have gained weight on their current HIV treatment might be able to reduce their weight gain or even lose weight by switching to a different regimen. We have our 5359 study, which is looking at whether long-acting injectable antiretroviral therapy might be more successful in individuals who have difficulty adhering to standard of care oral HIV regimens. And then we have our EXIT CJS study, which is focusing on medication treatments for individuals experiencing opioid use disorder who have recently been involved in the criminal justice system. And then if you want to get more involved with us, you can contact us by email, researchwithaheart@njms.rutgers. You can give us a call at the number on the screen, and you can always learn more about us at our website, rwah.rutgers.edu. We have a lot of exciting info there because you don't want to hear me talk all day about all the exciting stuff we do, so you can check it out there. And before we proceed, most importantly, I just want to thank everyone for attending. Like I said, we have an exciting program in store, but obviously without an audience, that doesn't really mean that much. So thank you so much for joining us. If you want to follow us, please keep in touch. You can follow us at Research with a Heart, Facebook and Instagram, or at RWAH North. And now, more excitingly, I'd like to introduce you to the panelists that we have tonight. So first up, I'd like to introduce Rondalia DeShields, who is the Director of the Clinical and Treatment Services at Rutgers, New Jersey Medical School Department of Medicine Infectious Disease Program. She has over 23 years of experience in HIV care and treatment and prevention, and 13 years of experience in clinical research. So she's a pro at anything research, anything infectious disease, and her passion is to improve the lives of underserved populations with a focus on women and LGBTQ communities. And she enjoys nursing and developing programs to help promote community and population health. And then next up, we have Raquel Reyes, who has recently obtained her doctor in nursing practice and is dual certified as both a women's health nursing practitioner and nurse midwife from Rutgers, New Jersey Medical School of Nursing in May of 2022. And she began her work in healthcare overseas as a nurse in Spain and then in England. And then in 2009, she became a registered nurse for the state of New Jersey, where she first encountered community-based women's healthcare services, which later became her passion. And currently, she works as a women's health nurse practitioner at University Hospital in Newark in the infectious disease practice. And she also works as a nurse midwife at Newark Beth Israel Medical Center and forensic nurse examiner for Union and Somerset counties. And then next up, we have Shobha Swaminathan, who is the Associate Professor of Medicine, Director of HIV Programs, and the Clinical Research Site Leader at Research with a Heart, our NIH-funded clinical trials unit. And Dr. Swaminathan is the principal investigator of many clinical grants to provide HIV testing, care, and treatment. And her research interests include clinical trials for the HIV treatment and prevention, and she is the site PI for multiple HIV testing grants. And she also leads a very active community engagement team. We're the best community engagement team, but I'm biased, dedicated to increasing awareness about HIV and the importance of clinical research in helping to address the HIV epidemic. And on that note, before we get into the discussion portion of our program, we have a brief slide presentation from Dr. Swaminathan.
So thank you, Rachel, and thank you to all of you for coming up and attending this virtual event, despite the beautiful weather that's outside. We'll try to keep the slides will be minimal, I promise you, because we really wanted to use this opportunity to have a discussion about women's health, which is much needed in our area. And when we think about women, HIV epidemic, people frequently, look at vulnerable populations, such as men who have sex with men, are transgender patients. But, in New Jersey is one of the highest rates of women living with HIV in the entire country. Currently, account for about 31% of all persons living with HIV in the state, which is much higher than the national average of just about 18%. What's even more troublesome is that, certain populations are more vulnerable. In fact, 88%, the majority of women living with HIV in New Jersey are among Black or Latinx women, showing that, it really disproportionately impacts minority women more so than others. Next. And so when we think of in that background, so then you think about people living with HIV. Okay, well, maybe new cases are going down. And this graph just tells you the number of new HIV infections that have been diagnosed amongst cisgender women in New Jersey over the past 10 years or so. In general, you will see that till 2018 or so, you've seen a gradual decline. And I see there's a big drop in 2020, but that's actually, I would say, a false drop because of COVID. There was a much decrease in testing, so I don't think that number is accurate. What's worrisome is in the 2019 and 2021, there's been a slow increase in the number of new infections. So despite effective treatment for HIV, despite the availability of prevention options, we really should not be seeing an increase in new infections in any group, much less so amongst cisgender women. Next. And so in that background, what can we do to prevent new infections? Well, of course, PrEP or pre-exposure prophylaxis. The CDC simplified things. Yes, there are multiple groups who might benefit from PrEP, but the simple way is discuss PrEP with anyone who's sexually active. So it takes away the bias for, how many partners, what type of sex, just discuss PrEP, keep it an open-ended question. So it takes away the provider or anyone else trying to make judgments about people or having biases. And secondly, prescribe PrEP to anyone who asks for it, because we know that it is very safe and effective when prescribed, but it's not going to work unless we actually prescribe it. So, if you can remember anything from our entire discussion, I think that would be the key take-home point. So what are the options available for our women? Next. And before we get to that, so why is this important? So this is something that says you have a large proportion of individuals, in the state and the country who would benefit from PrEP, right? Of the people who would benefit from PrEP, how many are actually getting PrEP, right? So what that says is the more number that are getting PrEP, so the higher the PrEP to need ratio, that means you're doing a good job of outreaching in that population. So when you look at overall, okay, let's look at if they're all the people who've gotten PrEP in 2021. And when they looked at that, they found that women accounted for only 8% of all the PrEP prescriptions. Now, if you remember, I said women accounted in New Jersey, in the US, at least 18% of all new infections. So you had 18% of new infections in women, but only 8% of women, or total women, are actually on PrEP. That tells us that providers and women themselves aren't actually thinking about PrEP when it comes to cisgender women, showing that there is a big gender gap in prescribing PrEP between cisgender men and women. So for every new HIV diagnosis among cisgender male, you have 11 patients who are on PrEP. That's great. There should be more, but at least 11. For women, it's less than half, only 4 PrEP prescriptions. So we have a lot of work to do to increase awareness about the need for PrEP in women. Next. Currently, we have only 2 options. And I say only 2 because we do need to have more options. There is one pill once a day, tenofovir or TDF-FDC or Truvada, as most commonly known. And the other is the injectable medication cabotegravir, brand name Aperture, which is given as an intramuscular injection every 8 weeks. Okay, so every other month. So you can either take a pill a day or you can take an injection every other month. These medications, when taken, are like 99% effective in preventing new infections among vulnerable populations. And we really should start thinking, yet, even though we've had, Truvada has been around for over 10 years at this point, but we still haven't made a dent. So we hope to use this discussion to perhaps talk about some of the challenges and barriers and how we can, as providers and as a community, help support this vulnerable population.
Thank you, Dr. Swaminathan, for that introduction to our panelist discussion. And before we start, I wanted to remind everyone that there is a Q&A. So if, as you hear people talking, you have questions or thoughts, you can drop them in the Q&A, and then we can ask them to our panelists at the end. And so the first question that we have for the panelists is, what are some common barriers to healthcare access for women in the community?
Hi, I think I'll take that one. So common barriers, what we found over the years and some of the work that we've done, and even representing on an international level and local level, there's lack of safe spaces for women to go to feel comfortable about talking freely about their sexual health. And we found that to be common, and whether or not that's around people making, their fear of lack of knowledge of terminology, how to talk, whether or not it's their perception of how the provider is treating them or how they feel. And because, as women, we feel, we go by getting a sense of people. So the fear of stigma and judgment, I find to be a great barrier for women to access. In addition, we have a lot of things on our plate. So we're a mom, some wife, partner, etc. And it becomes difficult to juggle our everyday activities and life. And in part of that, it's difficult for us to go to many, like just another doctor, included, just another doctor. Come about to is really trying to promote one-stop shopping to be able to offer services services in one place to decrease that having to go around to different places. And then the last thing I guess I would say is navigating the healthcare system, because as you know, it's things that we have for me to sometimes call the insurance company, and be placed on hold, or someone, gives you a referral or tells you that you need to go here, or even navigating when you come in to a setting like this and you're uninsured. And that presents, they send you to what we call in New Jersey, charity care. And that all of that can be very overwhelming for women, and definitely places a barrier for them to seek out to learn more and be aware of PrEP. I don't know if anybody else has anything to add to that.
I think you summarized it very well, but I think all of those things start with the awareness that you should actually think about it. And I think that's really provider awareness, self-awareness. We listen, none of us want to think of ourselves as being vulnerable to any particular thing, but at the same time, it is important to know what we can do, because this is something that can be addressed, provided there's systems in place like navigators and clinics that will provide you the space to have open and honest conversations about this.
I just wanted to add that in terms of barriers also, making aware. I think another huge barrier for women is have awareness of this product and availability. It's not sold for us in that aspect. It's mainly focused for other population. I think it's very important to spread it by word of mouth or through more media, so our cisgender women are more aware of this.
I recall maybe 5 years ago, we had done a study here, and we had a focus group. And the focus group, there were about 20 women in a room, and we were talking about PrEP, and they absolutely had no idea what it was. They were not familiar with it. They had never heard of it. They didn't, some said they didn't know it was for me, so really that, and when you look at the commercials on TV, it's even not geared towards women per se. And it's amazing with us being, us Black women being a large count in the HIV positive, it should be geared towards women, and messages should be geared towards women.
And on that note, talking about women and healthcare and everything, so who should women talk to about their sexual health?
So it's always a silent thing. No one asks, no one tells. And I think if the patient doesn't want to talk about it, they don't have to. They can just come and say, "Hey, I want the medicine." If they've found out about it, right? You have to feel comfortable, and also I think you have to build a rapport with the patient. But they should feel comfortable speaking to anybody about this and not being judged or stigmatized because of that. Again, and that's why I say, if you go, you can ask for it. You're not obligated to disclose your sexual health. Can it help me in certain things and what I can recommend for you or anything? Yes. But again, you don't have to, but we can build a rapport and start talking about things.
If I may add, the one thing is also making it routine, as part of routine for everybody. When you started thinking, Raquel, I thought of the last time I went to see my GYN. I don't know that anybody's asked me a sexual history in forever. I look a certain kind of way. I'm a doctor. People make assumptions about, about the patients. And I think, and that makes it stigmatizing. So if on the other hand, you just make it the same across the board. Like, I'm going to ask you because I think you are a certain person, or I'm not going to ask you because you're not. That's inserting our bias. So I think routinizing it, making it across the board, gives them an answer. They know that if they want to report it, maybe, but maybe at the next visit, they know that you will listen.
And absolutely, I think it's definitely important. We don't talk about things like pleasure. Are you having issues during sex? Those things I think we should be talking about. Like, why shouldn't women be talking about that? And it's always been told to, oh, we shouldn't talk about this, or there's bias. You're like, oh, she's a cisgender woman, she's not going to be doing this, I'm not going to offer it. But I think it's very, very important to speak about those things.
And so along that thread about women awareness and discussing with their providers, so why should HIV matter to cisgender women?
So it goes back to what I kind of introduced, saying, they are one of the groups they are a vulnerable group. Maybe not every cisgender woman, but particularly depending on where you are in your local epidemic. So certain parts, the Essex and Hudson counties are both considered, high prevalence areas that identified one of, 2 of 48 counties in the country that are higher rates of new HIV infections, right? So additionally, New Jersey is one of the states where we have, higher numbers of women living with HIV. So it should matter to them because it is about their health. It's about their family's health. And we know that, a healthy woman is able to offer a healthy environment to her children because women are so important and to their, children's well-being. And knowing your status ahead of time helps you plan your life and give you control. You do have the option, the independence to make decisions about yourself to see whether you want PrEP or not. When you're choosing to get pregnant. So knowing the status will help you make decisions for yourself independently, in my opinion.
So then if a woman is aware of HIV and her risks, how can she reduce her chances of contracting HIV?
So we all know, definitely, it's always said male male condom, female condom, but definitely we can protect ourselves a lot more using this, by giving PrEP and taking PrEP every day, and I get it. A lot of times you don't want to use that condom, or they don't want to use that condom, but at least you're protecting yourself. You're not protecting yourself against other STDs or other STIs or against pregnancy, but at least you're protecting yourself against HIV. I think it's very important. At least you have a choice.
Right, it's about the option and the freedom to make decisions for yourself. One of my patients who's on PrEP, and so when I talked to her, she said that her partner is living with HIV and is undetectable. She says, but this is what you tell me. Listen, doc, I can't trust him. I need to know that I can protect myself and be okay for me and my children. So I want PrEP. So I give it to her.
And I think it's also very important, we also have the monogamous relationship, the partners has HIV, and it all falls on the partner, but this, you get to be 50-50. You get to also be part of that undetectable and untransmittable. You don't have to put it all on your partner. You can also be part of that protection with PrEP.
And so what about a woman who maybe is pregnant? How can she protect herself against acquiring HIV? How do her risks change under those circumstances?
So definitely the good thing about PrEP, at least with the oral medication Truvada, it is permitted in pregnancy and during breastfeeding. And we definitely recommend it. You can definitely take it. And the thing is, with pregnancy, if you're not aware of your status and you were to become HIV positive and not treat it, you can transmit that to your child. If you are aware of your status, you can take medication to avoid that transmission. But I think it's very important that if you don't know it, get tested. And if you want to protect yourself against that, definitely you can take PrEP during that stage.
Okay, and so far we've talked about the risks of women and HIV overall, but what about women who have sex with women? Do they have a different risk profile? Are there different things that they should perhaps be aware of?
So again, it's about protecting yourself. Yes, you can be in a relationship with with another cisgender woman, or with whoever you decide to be with, however they identify themselves, but you don't know what they might be doing. Also, they might be having receptive vaginal intercourse with a male, and you don't know that. I think, again, it's about protecting yourself, in that aspect.
Right, and people can have more than one way of acquiring HIV, like there have been cases of women who have sex with other women where their partner may have acquired HIV either because of sex with another male or injection drug use, or, things outside of the relationship. So there are other things that might contribute to a person's vulnerability.
So also, in terms of determining risk, what about people in long-term partnerships, marriages, relationships? People might be in a long-term relationship and think, okay, I don't have to worry about that anymore. Should that still be a concern to them?
Absolutely. I definitely think it should be a concern because, sometimes for whatever reason, people living with HIV can become resistant to a type of medication, meaning it no longer protects them. And instead of being undetectable, what we call viral load can come out, and you might not know that. And again, we're speaking from prevention, right? It's a way of protecting yourself, and in that way, not getting that, because it's not intentional, sometimes, or maybe your partner decides depending on how they feel, they don't want to take the medication, and not letting exposes you to getting HIV. So again, it's prevention with taking PrEP.
Right, and what vulnerability is always on a spectrum, right? What's true today for you may not be true 6 months from now, may not be true 2 years later. So you always have to look at things at where they are at that point in time. Because I have many patients, who've been in who are currently in a monogamous relationship, right? But that may not have been the case 3 years ago, right? Or they were in a relationship, they had a fight, they temporarily broke up, then got back together, but during the breakup, they had sex outside the relationship. So there's so many ifs. So it's really about, so then how willing am I to have these difficult conversations with my partner? And how truthful are they going to be with all of that? And how much am I going to put my health and my safety in that other person's hands? Is ultimately, so that becomes a very individualized decision that you have to make for yourself, knowing these nuances.
Yeah, and so far this dialogue has really emphasized the importance of educating women on their HIV risks, but also the barriers to that communication. So then on those lines, my next question is, can you tell us a bit about the work that each of you have been doing to address this challenge and to get the word out there?
So it's very important that we continue to do outreach. We continue to be, like I spoke about earlier, representing women on national, international committees, local and statewide committees, to be able to make sure that women are a part of the cause, are a part of research. and educating others in general. Secondly, collaborating and working with CBOs, community-based organizations, and other organizations, hospitals, whether or not it's a homeless shelter or a food pantry, somewhere where women tend to congregate, and making sure that we are, educating the ones in charge, because then it'll definitely, hopefully, trickle down to have them understand the importance, and making sure that this is part of their education, a part of being a part of the community-based organization, counseling and education. So we've been, and the other big thing is having webinars, trying to just make sure that the information is disseminated and getting to the right population. And we could do that through focus groups. And we held a focus group. We held 2 focus groups back in between June and September of 2022. So continuing to keep your finger and pulse on the community, and trying to, and making sure that you're aware of what's going on, and how else better to do that is through community and the stakeholders that the gatekeepers.
Then, I'm sorry, Doctor.
Go ahead, Raquel.
So in terms of what are we doing also, now we have more women's health services in our practice. We have the Shine Clinic. It's the sexual health initiative of Newark. We have evenings also. We offer evenings because we have patients that work during the day. So you're more than welcome to schedule an evening appointment with me in that aspect. I'm available. And then it's not just about HIV, it's about prevention. We speak like, you're not interested right now in getting pregnant in the next 6 to 12 months. Again, PrEP does protect you against HIV, but maybe you don't desire right now a pregnancy. We can also talk about that. We can offer contraception if you desire that. We can talk about other screenings, with cervical cancer. A lot of our population doesn't know that, it's recommended to do it every certain time to prevent that. So there's multiple services that we offer here and we can discuss. Or you want to get pregnant and you don't know what you have to do. You want to get to a healthy point. Maybe you have a certain condition and you're afraid of getting pregnant, but you do want. That's also, we can talk about that.
Right. So I think we are all doing a lot of different things. And when I think about the work that we are doing, it's, we have a fabulous community engagement team that has been going out, meeting with organizations that provide services that could be complementary, because we don't provide everything here. We are, primarily a medical facility. We provide all the medical services and related, but, as Rhonda mentioned, working with other CBOs and other healthcare providers to partner with them, because you know what, there's so much work to be done. We can't do it alone. We need everyone to work together collaboratively. And that's our community engagement arm that goes out, does community engagement, does testing, STI testing, and then linkage to care. We have a clinic where we provide all the clinical services. And we have, our large research with the heart research team that, has in the past conducted clinical trials. Aptitude or cabotegravir, there were 2 studies that were conducted. We were part of the study conducted in cisgender men and transgender women. There was a parallel study conducted in Africa on cisgender women, again, that showed that the injectable Aptitude was actually superior and better and much more effective at preventing HIV infection than Truvada. So we do need community engagement, we need the clinical, and we also need research and clinical trials to find new medications. Because when we think about birth control, maybe 30 years ago, you had 1 or 2 options. We have a whole slew of options. What do you want? Do you want a pill? What kind of pill? How many do you want to take it every day? Do you want to take it 21 days? Do you want a holiday? Do you want an injection? Every 3-month injection? Do you want an implant? Do you want an IUD? there are so many options that a woman could walk in and talk to Raquel and say, this is what I'm looking for. And Raquel will say, okay, these are the options for you. For cisgender women, for HIV prevention, we have all of two. Either take a pill a day every day or an injection every other month. We need more. We need newer medications. We need more options because, women are our community is so diverse. We need to be able to give them choices that are best suited for their needs.
One of the last things is making sure that our providers in the community are educated on how to have these discussions in sexual health and how to not create a space that they feel unsafe to have these conversations. I think that's really important. We've talked about that throughout this discussion. That's really important. I know that there have been a couple of talks and I've attended about how to start the sexual health discussion, how to appropriately ask that, how to work with patients with the terminology that they are familiar with and that they would like to use, whatever they would like to say, whatever they would like to call their female parts, then that's what it is, and accepting them and meeting them where they are.
Okay, so similarly, on the topic of outreach and women's options, so Dr. Swaminathan, you mentioned that women just have two PrEP options. They have the pill, they have the injection, but how have these options changed over the past 5 years? Are we stagnating? Have we made great progress in the past 5 years? How have things changed compared to a few years ago?
I feel like when it comes to HIV prevention, women are a forgotten group. And I say that because Truvada was approved for, cisgender men and then cisgender women, but the sister medication, Descovy, which is the newer form of Truvada, there weren't clinical trials done in cisgender women, Are we not as important as the men? Are we not, as vulnerable of a group? Thankfully we do have aperture, but it took about 10 years after Truvada was first released to get approval. So it took us 10 years to go from one medication to two. There is a big movement to have additional prevention options available, either pills that can be taken less frequently, or injections that can be given. There is a study ongoing currently in Sub-Saharan Africa that is looking at a new medication for HIV prevention among women. That's an injection every 6 months. That would be, almost similar to almost like the Norplant, which is an implant. So there are clinical trials looking at injectable medications that are less frequently than every other month, because let's face it, I don't have the time to come into the doctor's office necessarily every other month. If I'm working, if I've got young kids, I don't have the time to go to the doctor. So I want something that's less frequent. I want something that I can get the pharmacy, the pharmacy down the street, than actually walking into the big building in the healthcare center, making an appointment, going through the front desk. All of those things are all just barriers. We need to make it as easy as possible for women so they can get it, so that it's more accessible to them. And there are other research options, including things like patches. Again, I'm talking like 5-10 years down the road, but other things that are being considered. And, clinical trials are the only way we'll figure out to make sure that these medications will be safe and effective for the people who need it the most.
So in addition to that, how important is it for someone to take a pill every day? We've talked about the benefits of injectables. Are injectables the best PrEP for everyone? Are there some people that maybe a pill would be better for? What is the best option that's out there?
The best option for you is the best option that you think you can take. And I say that because I have many patients for whom I can't take a pill, like, I've taken a course of antibiotics and I'm probably just as guilty, by the day 6 or day 7, okay, you know what, I'm better. I don't need this anymore. I can skip. So if you are the kind of person who you feel like you can't take a pill, you can take a pill every day, then that's fine. You don't have to come to the doctor's office until every 3 months for the testing. That's great. But if you think that I don't have a safe place to store my meds, I'm afraid my partner is going to find out that I'm taking PrEP. There's a lot of stigma associated with taking PrEP because of misconceptions about the type of people they are. So, but if you can come in every other month, just get the injection, then that's fine. The injections can cause some pain at the site of the injection. No one likes injections, but most people in clinical trials and in my use, once they get used to the injection, they generally tolerate it very well. So whatever works for you. The one thing for Truvada, particularly for women as compared to cisgender men, they do have to take it much more religiously because it takes almost 3 weeks for the Truvada to get enough levels in the vaginal tissue to be adequately protective. So you can't afford to miss as many doses. Maybe you could miss maybe one pill or one pill a week maybe, but for the most part, you've got to be 80 to 90% adherent for it to be maximally effective.
And that's a really good point. And so now that we've expanded on our current options, and we did touch upon it briefly, what do you all predict will happen in the next 5, 10, 15 years down the road with treatment options?
My dream is to have a whole spread. Okay, like how we have birth control options, where you have, pills, different kinds of pills, depending on what you have, different types of injections, a patch, an implant, maybe a dual prevention pill. You want to prevent HIV and you want something with birth control. Hey, just take this pill. It'll take care of both. Maybe a ring. So there is a ring that's approved by the World Health Organization. It is not FDA approved, but it is approved for use internationally. It's a vaginal ring. You just, you insert it every couple of weeks and you change it. Easy. Nobody knows you have it. It gets protective. So, it's really having, so when women come, I can actually have a meaningful conversation about, well, what are you thinking? What are you feeling like today? Do you feel like you want to do this, or this? And then going down the road and having a conversation as opposed to saying, okay, here's a pill and here's an injection, pick one.
Absolutely. In terms of that, I'm very hopeful. I'm always thinking positive. And I do, and I hope that more providers will be open to prescribing. And because sometimes we even have patients they say, I went and I asked for it, but they won't prescribe it. They don't do that. I think healthcare needs to be more knowledgeable about this. Primary care can prescribe this. You just have to do certain follow-ups, but it shouldn't be just for one specialty to be giving this out. I think hopefully, in the future, don't know how far, but that will be the case, that it will be more accessible to our population.
Yeah, and Raquel, that's a great point about who should be prescribing, because women aren't going to come to infectious diseases. They probably aren't even going to go to primary care. I don't have a primary care. I have a gynecologist, but I don't have a primary care. So really, if you're talking about particularly women of childbearing age, they all go to their GYN for their annual well visit. So really educating, OBGYN providers and trying to increase, awareness. I will say on the practical side, it would be great if our healthcare system was such, and we didn't really get into that because you could have a whole hour about insurance barriers and how to overcome that. And that really is a big part of why some people are afraid, because of the amount of loopholes you go through to try to get approval for some of these medications. But really, and as Raquel mentioned, we are working with both our internal medicine colleagues at our institution and with that GYN to try to increase, to work with them to increase PrEP prescriptions in those areas, because, well, women who are otherwise young and healthy, generally that's where they go for routine care.
And so this has been a really robust dialogue. And so the last question that I have, which I know we briefly touched upon, but I just thought it'd be good to emphasize, was how do we become comfortable talking about HIV and sex? Because both of those can be taboo for some people independently of each other. And I feel like this conversation has really emphasized the importance of getting the word out there. So how do we make people more comfortable?
So one of the things I spoke about about educating providers, but one of the biggest things I think that will make a difference is working with the medical schools where medical students are in school and having it be a class about how to talk about sex or sexual health, and that includes nursing students, that includes nurse practitioners, physician assistants, really working with the providers and having that either be a focus, a class, learning, proper pronouns, LGBTQ language, and accepting, and really one of the biggest things is about learning your own stigma and your own bias. And I think that one of the places definitely to start is with medical schools and students who are in the healthcare field. And then hopefully that would be my dream, is that the medical field will become more comfortable about having these conversations and know how important it is to be able to create safe spaces for women.
I definitely agree in that aspect. It is true now, the education, they're speaking more about it. But I definitely think important, if you as a provider don't speak to your patient about this, your patient might not know that can happen. I can give you an example, like with my patients, I end the conversation, is there anything you would like to discuss? And I always say, are you having any problems? You want to ask any questions in terms about sex? And some of them I can talk about that. I said, absolutely, and I tell them, like, you don't have to have pain. You don't, and there, a lot of these things, they think they just have to live with it. And I think we have to feel as healthcare providers comfortable asking that question, getting rid of that taboo, we're not going to talk about this here. I think we have to. And that way we can also make our patients see that it's okay to talk about this. It's fine.
And incorporating that as part of the wellness visit for all patients, because it's just routine. The way to destigmatize that is to make it routine and normal to talk about it all the time, not just when you think someone has an STI. It's about all the time. And actually, the best conversations are had when you're not in a crisis, because then when a crisis happens, you actually can react appropriately.
Great. So I wanted to open up the Q&A to questions from our attendees. And we do have one question that I wanted to present to our panelists. So the question is, I'm uncomfortable telling people about my HIV status due to past experiences. What advice do you have for me to help me communicate or figure this out?
I think disclosure can be quite challenging. And it really, not everyone needs to know anyone's HIV status. It becomes a very personal decision about who you feel comfortable with sharing, information that's vital to you. I have many patients who feel burdensome. So I think it starts with figuring out who it is that's important for you to share that information and what you want from it. Because we are human beings are social people, so we like to connect with our family, our friends, and our support. I have had some patients come bring their family member to their doctor's office or their mother to their appointment so that then we can have the conversation together. So there's someone else who can reassure the family member or the friend or the significant other to talk about, that they will be okay. It's some people living with HIV have, a normal life expectancy. They should be undetectable and they should be able to go to work, get married, have kids. They are to have, you just happen to be living with HIV infection. HIV does not define you. But because of the stigma associated with it, we advise our patients, if you're in a relationship, that person probably has the right to know about it, but then try to make sure that you are in a safe space because you want to make sure that you don't get hurt, because some patients are concerned about, intimate partner violence. So we want to make sure that when you ever having the discussion about disclosure, it is in a space that you feel safe and that with a person that is not going to retaliate, just as like baseline safety concerns. And you can talk to counselors about ways to having those kinds of conversations for more in-depth information.
And along those lines, actually, someone commented that PrEP sounds like it should be an empowering versus a sign of risky behavior. And I just thought that was a great comment. I just wanted to read it. I think it's a great takeaway message from the conversation that's been had. And on that note, we don't have any more questions from the Q&A. So I just wanted to take a moment to thank all of our panelists for our conversation that we've had this evening. I've learned a few things even though I work here, but I think it's been really great. I don't know if either of you have any final comments that you'd like to provide, but in light of that, I'd also like to thank all of our attendees for joining us. On behalf of everyone at Research with a Heart, we really, really appreciate you joining us tonight. And I hope you learned something new. Thank you.
I just want to say thank you to Rachel for, putting all of this together. I know it took a lot of work and coordination. Thank you to all our attendees. But most of all, it feels so great to be in a panel with so many other successful, powerful women. We, a lot of us, within our program, we have women in leadership position, and it's really great to see, women supporting each other. And I think there's a lot that we can do to help each other out as women. And so, thank you.